Welcome to part 4 of Integumentary. We're going to discuss pressure injuries. Pressure injuries, also called pressure ulcers, pressure sores, decubitus ulcers, decubes, and bed sores, are areas of localized damage to the skin and underlying tissues that usually occur over a bony prominence or can be related to a medical device. These develop due to pressure compressing soft tissues for a prolonged period of time, or when soft tissue has pressure along with shear or friction. Pressure injuries cause a lot of pain, decreased quality of life, and a lot of money is spent on treatment. $2.2 to $3.6 billion each year type of money. These will also cause 60,000 deaths a year. The damage occurs when the pressure applied to the skin is greater than the normal capillary pressure. This means blood cannot flow into the capillaries and cells lose oxygen, which is called hypoxia. Then those hypoxic cells start to die, which is called ischemia. Friction and shearing forces to the skin can also cause damage to the skin and result in cell damage and death. Skin that is moist from urine, stool, or sweat, called diaphoresis, can increase the chances of damage with pressure or friction and shear. Friction occurs when the skin and the sheets or mattress rub against each other, causing the skin to move while the body stays in the same place. Shear forces are when a person slides down the bed or when we pull the person up in bed and we don't have the body completely off the mattress. We're sliding that skin along the mattress. Every part of the body that has a bony prominence is at risk for pressure injuries, from head to the toes. This picture shows the most common area for pressure injuries, but honestly, anywhere can be a risk if there's a medical device. I've seen pressure injuries from oxygen tubing, armbands, allergy bracelets, restraints, Foley catheters, SCDs. You name the device and it's probably caused a pressure injury. The locations that are most at risk are wherever locations the patient's laying on at that moment. If they're on their side, then their ears, shoulders, hips, knees, and ankles are at risk. If they're on their back, their head, elbows, their entire sacral buttocks region, and their heels are at risk. If the person's up in a chair, their spine, their entire sacral and buttocks region is at risk. This is why we need to be repositioning our patients at least every 2 hours. We must change positions to get the pressure up off of those areas. We also need to be checking medical devices every 2 hours as well. Who's at risk? So in actuality, anyone who's hospitalized is at risk for a pressure injury. If they're sick enough to be admitted, they're sick enough to develop a pressure injury. Some people are at a little higher of a risk. This will include people whose level of consciousness is altered, spinal cord, brain injuries, neuromuscular diseases, or those who are comatose. These people cannot or may be limited on how much they can move on their own and are dependent on healthcare workers to move them. They also can't tell us if a spot on their body hurts or if they're in an uncomfortable position. People with excess moisture on their skin, especially urine or stool, are at a huge risk for pressure ulcers as these body fluids have enzymes and bacteria that can eat away at the skin. I've mentioned poor nutrition several times. Low protein intake causes low albumin levels, which causes less nutrients to the skin and poor wound healing. People with chronic illnesses like diabetes or those requiring prednisones are at high risk of decreased circulation, increased risk of infection, and can have poor nutrition, all increasing their risk. Elderly are at higher risk due to circulation issues, medication, less adipose or fat tissue, and changes with the skin that occur with age. The biggest factor that makes a person at risk has to do with how fast the cells will incur damage. This depends on how well the underlying structures, meaning the blood vessels and collagen are, can assist in redistributing pressure. So many things affect who's at risk. Also, we have healthcare providers who are too busy or too lazy to reposition their patients. Or we have patients who are physically too sick to move. Like this patient who's prone on continuous dialysis, on a ventilator, and on at least 7 IV medications and tube feeding. One of the best prevention strategies we have for pressure injuries is assessing a person's risk factor. We need to assess their level of mobility, neurological status, and circulation status. Those three will give you an immediate idea if the person's at risk. We also want to evaluate the person's nutritional and hydration status, looking at any lab values we have as well. We need to look at the person's ability to eliminate urine and stool, especially if they are incontinent, and we need to review their medications to see if they're on anything can cause or affect any of these areas of focus. There are also evidence-based risk assessment scales used in healthcare. This picture is of the Braden scale, which is used by many Phoenix area facilities. It uses a scoring system to determine the risk. The lower the score, the higher the risk. The higher the score, the lower the risk. The scale is only as good as the person who is filling it out. You actually need to assess your patient to get an accurate number. When we have a patient with a pressure injury, our skin assessment becomes a lot more in-depth and a lot more important. There are potential legal and monetary implications to pressure injuries, so we need to do a thorough as possible assessment. First, we need to be assessing our patient's skin on admission, documenting any skin issues we see when they get admitted. After that, we need to assess their skin at least twice a day, more if needed. When we do the skin assessment, we need to look at every pressure site for any erythema or redness. If there are any areas of erythema, we need to check for blanching, which we'll discuss on the next slide. We need to palpate the pressure sites for increased warmth. In addition to redness, we're looking to see if there are any breaks in the skin, regardless of the cause. Any breaks in skin can become major issues, so we need to assess and document and treat them. If we do find a pressure injury, we need to measure the length from head to toe, width from side to side, and depth if there is a depth. We also need to assess for any undermining, tunneling, sinus tracts, or fistulas. And we also need to assess any drainage and odor. If we find any erythema, especially on pressure sites, we need to check for blanching. We're going to use our gloved finger and press on the red area to see if it turns white, like the picture, before it goes back to red. If it turns white, then that tissue is getting blood flow, which is good. But the redness is still telling us that the blood flow is diminished and we need to relieve the pressure off of the spot before damage occurs. When we relieve the pressure off the site, the redness should be gone in less than an hour and a half-ish, max of 2 hours. If the redness is still present after 2 hours, we did have some tissue damage. If it does not blanch, we have a problem. The patient has developed a pressure injury. When we do our skin assessments, sometimes we'll find a dark purple or maroon spot on a pressure site. It kind of looks like a bruise. These purple spots are called deep tissue injuries, and they are the first type of pressure injuries we will discuss. These pressure injuries are considered unstageable because we don't know the extent of the injury. Usually the skin is intact, but it might not always stay intact. When we palpate this purple spot, it may be painful, it may feel firm, it might feel mushy, or it can even feel boggy. When I think of what boggy feels like, it's like a wet sponge feeling without all that water seeping out of the sponge. Sometimes a purple spot can have a different temperature than the surrounding skin. It can either be warmer or colder. The reason why we say that these deep tissue injuries are unstageable is because we can only see the purple surface. We do not know how much damage has occurred under the surface. It's like an iceberg. We only see the top of it. The damage can extend all the way through all the levels of the skin, through the fat, go into the muscles, and even deep enough to go to the bone. The treatment for deep tissue injuries is immediate and continuous pressure relief off of that spot and monitoring to see if that skin opens up. Besides deep tissue injuries, we have 4 stages of pressure injuries. I'll discuss each one more in depth, but here's a quick overview. First, we have a stage 1 pressure injury. This is when the skin has a non-blanchable erythema spot of intact skin. It is a red spot on a pressure spot that will not blanch. The second stage is a stage 2. This is also called a partial thickness wound, and it's just like a stage 1. It's a reddened area over a pressure site, but the skin is no longer intact. Next, we have a stage 3 or a full thickness wound. We now have damage that has gone into the subcutaneous tissue, but it's not involving any underlying muscle or bone. Lastly, we have stage 4 or full thickness wounds. Now the damage has gone deep enough to affect muscle, bone, tendons, and ligaments. We also can call any wound unstageable if we cannot determine how deep it's gone because of drainage or necrotic tissue that could be in the way. All right, let's talk a little bit more about stage 1 pressure injuries. Like I said, there are non-blanchable areas on pressure sites. The skin is intact, meaning there are no openings, blisters, tears, or anything. On light skin, these are usually easy to see, but on darkly pigmented skin, they can appear just as dark areas. These often get missed until the stage 1 has developed into a stage 2 and the skin is broken. Stage 1 pressure injuries have no drainage. To treat these pressure injuries, we need to relieve pressure immediately and continuously. We need to maintain good nutrition, including protein, as well as fluid and electrolyte balance. We want to avoid moisture on that area, especially if the patient has incontinence. We also want to reduce friction and shear by using a pressure relieving surface, such as a mattress topper. Some wound care nurses will have us place a pressure relieving dressing over the area to help prevent pressure and friction and shear. Next, we have stage 2 pressure wounds. This is a non-blanching reddened area on a pressure site where the skin has opened. It could be a blister or it could be complete loss of the epidermis, but their skin is broken. I want to say that this is used for pressure injuries only. We do not use stage 2 to describe skin tears or tape burns or perineal dermatitis, maceration, or excoriation. Staging is only for pressure injuries. It's not uncommon for a person to have multiple areas with different stages at this point. The picture on the right-hand side shows a deep tissue injury, a stage 1, and areas of stage 2. Stage 2 pressure injuries can develop drainage and slough. Slough is dead tissue that's fallen off the skin. We treat stage 2 pressure injuries with cleaning with sterile saline or a commercial cleansing product if ordered by the wound nurse or the provider. We also put dressings on these pressure injuries. Stage 3 pressure injuries have extensive tissue damage that extend to the subcutaneous layer, but we do not have any damage to muscle, bones, or tendons. These wounds will have drainage and can have slough, but the slough does not obscure our ability to see how deep the injury goes. The yellow tissue we have in our first 2 pictures is slough. Stage 3 wounds may have undermining and tunneling present. Treatment for these wounds is very painful, and if there's any slough or necrotic tissue present, it needs to be removed. We do place dressings inside and over top of stage 3 pressure injuries, and all of this care requires pain medication before, during, and after because of how painful this can be. Lastly, we have stage 4 pressure injuries. These injuries have extensive tissue damage that now affects muscles, bones, and tendons. There is probably tunneling or undermining present. The first picture shows a tendon right in the middle, as well as some undermining kind of over about like 1 o'clock, 2 o'clock, 3 o'clock-ish if it was a clock. I can't tell for sure in this picture if there's any tunneling, but there's definitely undermining. The second picture has a little white area next to the D, which is actually exposed bone. Treatment for these wounds is very painful, and if there's any slough or necrotic tissue present, it needs to be removed. We do place dressings inside and over top of stage 4 pressure injuries. And again, just like stage 3, they require pain medication before, during, and after. Oftentimes, surgical intervention is needed to remove all the dead tissue in a stage 4. If we can't see the wound base, like if it's a deep tissue injury or something open like these pictures, we call them unstageable. We can't see how deep the wound really is. In the first picture, there's too much slough present to see how deep it goes. After the slough has been removed, we may be able to see how deep it is and then be able to stage it. The second set of pictures is showing pressure injuries covered with eschar, which is a thick black scab-like tissue. We can't see the wound underneath the eschar. Depending on the body area the eschar is present, depends on how and if we will remove it. If it's on the heel and we go to remove it, the heel bone is right there. So a lot of times they'll leave the eschar on heels. If it's in the sacral area, a lot of times they will remove it because there's a lot more tissue in the area and it's not right up against bone. As I mentioned, that we only use staging for pressure-related injuries. One issue we have in nursing is we just see wounds and we want to stage them. This is wrong, and the wrong diagnosis can change the way we treat the issue, and not for a good reason. People can have wounds on their legs that have nothing to do with pressure, like these venous ulcers. These ulcers are caused by poor venous circulation to the lower extremities. People may call these venous stasis ulcers because the blood just pools in the legs and doesn't have the circulation to return it back into circulation and back to the heart like normal. The circulation is so bad that the tissues swell, and all of that extra fluid causes the skin to break apart and form ulcers. Venous ulcers are necrotic, crater-like lesions usually found in the lower legs around the medial malleoli. These are very slow to heal because of poor circulation, and oftentimes they will not heal until the circulation is surgically restored. Before these ulcers occur, we'll see edema in the lower legs, and the lower legs will start to change colors to a darker brown, and the skin will get thicker. There also may be hair loss in this darkened, thickened skin. Another type of ulcer that commonly gets mistaken as a pressure ulcer is an arterial ulcer. Like venous ulcers, these arterial ulcers can be caused by poor circulation, but poor arterial circulation. The legs aren't getting the oxygenated blood to the tissues. Arterial ulcers are usually found on the distal body parts, toes, heels, malleoli, where it's far from arterial circulation. Arterial ulcers usually are very pale with an ischemic base, meaning dead necrotic-like tissue. The wound is well defined, almost like a perfect circle. Most of these patients do not have palpable pedal pulses, and if the ulcer is in an area where hair would be present, like the malleolus, the hair will be absent. And this is the end of part 4.